We're going to move on to talking about treatments in psoriasis. So, you've got your topical treatments, phototherapy, systemic treatments, including conventional treatments, and then we'll move on to a bit more about biologics and a bit more about pathogenesis of psoriasis when we're talking about that. We'll move to topical treatments. There are a wide range of topical treatments we use, but it's probably becoming a bit more streamlined in recent times, and we probably moved to systemic agents earlier than maybe was done in the past. So, in general, you should just encourage the regular use of emollients. We see ointment preparations tend to be more effective, but of course, creams and sometimes they're even more easily applicable for the patient. So it depends on patient preference. And if you want more information on emollients, particularly the ones used in the UK, you can click on the link here which is in the eczema section about that. Vitamin D analogs are very effective and they're very safe in psoriasis. The main side effect is skin irritation, and that's usually lessens with usage. And it is important to be aware, though, if they are using it excessively, it can result in systemic hypercalcemia. So you should use it as per the manufacturer guidelines. So kind of the original one really was calcipotriol, also called Dovanex, something you can use once or twice a day. You can also get it as a scalp solution. And the maximum use should be about 100 grams per week. And it's not suitable for using the face or the groin area as it's too irritating. For these instances, you can use something called calcitriol or Silcus ointment. And again, you can use this once to twice per day, as it's not as irritating as calcipotriol, so it's more suitable for textural and facial psoriasis. And you should not use more than 30 grams per day. We often use combination preparations, including the vitamin D analog and betamethasone. And so the prep we usually use is calcipotriol and betamethasone, and this can come in different formulations. But you can apply this daily for 4 weeks to affected areas. The treatment course can then be repeated after a few weeks if necessary. So there are different formulations, as I mentioned. You can use Dovabet gel for the scalp. You use a maximum of 1 to 4 grams per day. And they suggest that maybe you apply it to a dry scalp overnight and shampoo it off in the morning. Dovabet ointment is used for the skin, and you can use a maximum of 15 grams per day. It's very important that it suggests that you should only use it to a maximum of 30% of the body surface area. Stillerfo has the same recommendations as Dovabet. It's essentially the same ingredients, but studies from the company have suggested that the way it is formulated, it is more effective than Dovabet. So then topical steroids can be used alone. So as mentioned in a previous video, that they can be often used for flexural psoriasis. You might use a combination of Trimavate, which is a moderate steroid and antibacterial and antifungal agent. You might use them also for scalp psoriasis. And as always, be aware of the side effects with long-term use. And then some clinicians hold back on prescribing very potent topical steroids in psoriasis, as theoretically it could potentially lead to a flare of pustular psoriasis when using more at withdrawal. Now, there are other topical agents that are used that they're probably used a lot less nowadays, and I haven't seen them being used too much where I work in recent times. It used to be that they'd often be used for patients in a day treatment unit setting or as an inpatient. And so ditronol is one, and it is also known as atropine. And it's a very irritating substance. It's unsuitable for fair-skinned patients, the face and the flexors. And there's a crude form of it. And as I mentioned, this is often reserved for nurse-led treatments in the day unit. Now, there is a different type where you can get a short contact ditronol therapy. So patients can do this at home. And essentially, they apply to patches of psoriasis for a maximum of 10 to 16 minutes, and then they wash it off. And this can be quite useful, particularly if they have resistant localized plaques that are causing them bother. And it's important to let the patients know that it can temporarily stain the skin brown, purple, or orange, and also importantly that it can stain bed sheets or clothes. So make sure that patients are aware of this, making sure that they wear, old pajamas, old sheets, or whatever, so that it's not a big issue. Uh, and as I mentioned, it tends to be prescribed less these days due to advances of systemic treatments. And then another one was coal tar, and it comes in very many different preparations, creams, ointments, gels, shampoos. And I suppose we still do use it, particularly for the scalp, so it's useful. There are preparations such as Cocoas and Sepco, which I'll mention later. And then it can also be used in chronic plaque psoriasis. And Extrax is a mild preparation, and patients can use this at home. And be good for descaling plaques. For instance, I know it can sometimes be good to descale plaques prior to phototherapy, help the phototherapy work better. I know when I worked in Ireland, we used it a bit more, and it doesn't seem to be used too much where I work in the UK. I'm not sure if is that an expense reason, but I know in the past it was quite useful. And then you could go to more stronger things, but again, this is often used in their state treatments or as an inpatient. And these are various crude coal tar regimens. And essentially, at the start, you do a test patch area on a patient, see if they have bad reaction to it, and you use the low strength of it. And then if they tolerate that, you slowly increase the strength over time. And lots of dermatology departments will have different crude coal tar regimens to be used. So I'll just mention there's a few different combination treatments. So diprosalic and salicylic acid, 3% and beta-medicine. This is useful for thick hyperkeratotic scaly areas. So often it's good for the scalp, the palms, or the soles. And there's a diprosalic solution, which can be used for the scalp. And there's a diprosalic ointment, which can be used for the skin. For the skin area, they suggest the max you should use is 60 grams per week. Scalp psoriasis is quite difficult to treat, and it can cause patients a lot of issues. And the thick adherence scale that can build up, and it really can be very thick, and can block the penetrance of topical steroids. So we often use a keratolytic therapy, so something with salicylic acid in it. So diprosalic, as mentioned before, can help remove the scale. And it's important that you give them advice on how to apply the cream, the ointment, or the lotion to the area. So oftentimes you'd advise them to part the hair and apply it directly to the scalp. And oftentimes if you include the scalp with a shower cap and leave overnight and then wash off in the morning, it can help soften the scale. And it's important that you tell them not to really be picking hard or scratching hard at the scalp, because actually trauma can make it worse due to the Koebler phenomenon. And sometimes actually we use olive oil soaps in the day unit, and then recommend the patients to use them. And that is another way to soften the scalp. And the BAD has a good website, skinhealthinfo.org.uk, and this has a few good videos on how to apply treatments in scalp psoriasis. So if you go to that website, go to the support and resources and video guides, you'll be able to find that there. And so then there are other scalp preparations. So Cocoa's ointment is coal tar 12%, salicylic acid 2%, sulfur 4%. It's good for things like psoriasis, seborrheic dermatitis, and scalp where the scale is thick and adhered. You basically rub into the scalp, leave overnight with a shower cap, and wash off in the morning. And there actually is Dermavate at the scalp, which is also called Etrovix. This can be used for moderate to severe scalp psoriasis. And you use it, the other steroids aren't working, so things like diprosalic ain't doing the job. And you leave this on for 15 minutes only and then wash it off. And you do not use this for greater than 4 weeks at a time. And then there are various medicated shampoos and preparations that patients can use as much as they want, really. So ones include Capisol. This is salicylic acid, 0.5%, with a bit of coconut oil and a bit of distilled coal tar. Then there's polytar, which is just coal tar solution. And then there's alfosol 2-in-1, which is an extract of coal tar also. So if topical treatments aren't working, which is often the case, so usually if they've been referred by GP to dermatologists, usually topical treatments aren't really doing the job. So oftentimes the first consideration might be phototherapy. And usually the first go-to line one is narrowband UVB. This is also called TLO1. I think that's due to the type of light bulbs are used. So the brand or the manufacturer are called TLO1. And this is the first line phototherapy we use. and it can be localized, for example, just the hands or feet if you have the equipment, or it can be whole body. And it's useful for chronic plaque psoriasis and guttate psoriasis. I suppose one of the big issues with it is that it's quite time consuming for the patient. So they need to attend a phototherapy service, 2 to 3 times a week over a period of usually on average about 3 months. So, actually when they come in for the treatment, it's very quick, but it's just, the logistics of them being able to get the time to do that can sometimes be difficult. And then individual treatments, for them to come in and all that, and then to get the light shine on them, it can be usually as quick as 10 minutes. And as I mentioned, usually they'll come in for approximately 20 to 30 sessions. And it often results in an improvement, sometimes a clearance of the psoriasis for patients. And, sometimes it can last weeks, sometimes months, sometimes longer. But it often then recurs. And then often with time, if they've had a few courses, you often tend to lose the negative effect. And so risks with narrowband UVB, so it's common for them to get, a mild sunburn type reaction. And sometimes it can be a bit more severe, and you can get, if you're sensitive, if you've got a underlying photosensitive disorder such as polymorphic light eruption, it can cause that. Usually the skin is tested before with something called an MED test, which is they check various strengths of the wavelength of light, perhaps on their arm or back, and that can tell if a patient is particularly sensitive to that type of narrowband UVB at various strengths. It can also cause reactivation of herpes simplex virus. So if they're prone to getting cold sores or shingles, you should be aware of that. And if they're on photosensitive drugs, such as tetracyclines or things like that, can make them more sensitive to the sun. And, with really prolonged courses, it might accelerate photoaging. And also there's an increased risk of skin cancer with increasing cumulative dose. Really, with narrowband UVB, we are usually quite happy that if they've had less than 500 treatments, we're not overly concerned about photoaging or increased risk of skin cancer in a normal patient. And there's also a slight increased risk of cataracts, so we will get them to wear goggles that have UVB protection. And as I mentioned, current recommendations is that the ceiling of treatment should be about 500 treatments, which is equivalent to about 15 to 20 courses. And if they've had this amount of treatments already, they really should be getting annual review for a skin exam, looking for skin lesions. So Puva then is usually reserved as second line and in psoriasis. So, if narrowband UVB is not working, and I actually haven't seen it used that frequently recently in psoriasis, and I think that's really due to the increased risk of skin cancer. Now, it can be used in other dermatology conditions as it can penetrate a bit deeper than narrowband UVB, so it still definitely has a role. But yeah, usually we're a bit more reluctant in psoriasis with Puva. So again, it can be whole body or localized to the hands and feet. Tends to be more effective than narrowband UVB, and it might result in longer remission, but it carries a higher risk of side effects, particularly skin cancer. So UVA is UV radiation of wavelength 320 to 360 nanometers, and the P stands for psoralins. So psoralins are chemicals, and they make the skin temporarily more sensitive to UVA, and it allows it to be more effective at lower doses. And the psoralin can be introduced orally, topically, or sometimes it can even be mixed in a bath water solution that the patient can then sit into it. And the oral psoralins tend to be 8-MOP or 5-MOP, and you tend to give 8-MOP about 2 hours prior to treatment. And eye protection must be worn for 24 hours from the time of taking the tablets, as they are more sensitive to UV light and they're at increased cataract risk. And when getting treatments, glasses with UVA protection should be used. And just a tip is that if they are getting nauseous, taking the 8-MOP, then you can change that 5-MOP, and that sometimes helps. So the ceiling of treatments for Puva is 200 treatments at the moment. And again, if they've had over this amount, they should get annual review. And you'll often find maybe patients who historically got Puva, many years ago, might have gone over that limit. They should be getting annual review. They are at risk of skin cancers. So we'll move on to systemic treatment now. Now I've gone into more detail about medications such as methotrexate and cyclosporin in the systemic treatment section of this website, and I will include links where relevant here. But again, really, you want to consider systemic treatment if they have not had good enough improvement with topical treatment and phototherapy. And NICE in the UK tend to have quite well-defined guidance on this. So you should offer a systemic, non-biological therapy to people with any type of psoriasis if it cannot be controlled with topical therapy and it has a significant impact on the physical, psychological, or social well-being of the patient, and one or more of the following apply. So either the psoriasis is extensive, as defined by greater than 10% body surface area or greater than 10 PASI score, or the psoriasis is localized, but it is associated with a significant functional impairment and or high level of distress. So this might be if it's in a special site, such as if they've got very severe nail disease or severe scalp disease or genital disease, or if it's in very visible areas that's really bothering the patient. Or if the phototherapy has been ineffective, or if it cannot be used due to rapid relapse, or it's contraindicated for any reason. So NICE suggests that you should offer methotrexate as a first choice of systemic agent for people who fulfill the above criteria and have no contraindications to it. They also suggest that you can offer cyclosporin as a first choice who fulfill the criteria for systemic agent, but also that they need rapid or short-term disease control. So I suppose the good thing about cyclosporin is that it works quick. So if they've got a really bad flare and they need rapid control, it's an option. Or it can be used in palmoplantar pustulosis, or it is seen as a safer option than methotrexate if patients are considering conception, both men and women, and if they need systemic therapy. Then NICE goes on to say that you should consider changing from methotrexate to cyclosporin or vice versa when the response to the first choice is inadequate. They also suggest that you can consider acitretin for adults and only in exceptional cases for children and young people in the following circumstances. So if the methotrexate or cyclosporin has failed, or if people have pustular forms of psoriasis. So acitretin can sometimes be useful in pustular psoriasis. So NICE do suggest a potential regimen for methotrexate. So they say use incremental dosing. So you can start at 5 milligrams or 10 milligrams per week and gradually increase up to the effective dose up to 25 milligrams per week. And then the plan is to assess treatment response after 3 months at the target dose. And you stop it if the response is inadequate. So if a PASI score, that inadequate response is defined as a decrease of PASI of less than 75. So I suppose I should mention what PASI 75 means. That means that there's been a 75% improvement in the PASI score. PASI 50 means that there's been a 50% improvement in the PASI score, and a PASI 100 means that there's been a 100% improvement in the PASI score. So if a patient has not had a PASI 75, you might have to stop it. Or the other option is they might have only had a PASI 50, so 50% improvement in psoriasis, but they've had an improvement of 5 points in the DLQI score. So cyclosporin is another option, and generally you use may start at a 2.5 to 3 milligram per kilogram per day dose. And you could then escalate this up to 5 milligram per kilogram per day if there's no response at the lower dose. Sometimes you might even start at that dose if they have a very severe unstable disease that needs to be gotten under control right away. And again, you assess treatment response after 3 months at the optimal dose, and you stop the treatment if it's inadequate. And you really want to use the lowest possible therapeutic dose. And it's, as I'm sure you're aware, it's a short-term treatment. So if it's used for too long, it causes issue with blood pressure and really damage the kidneys. And so really you don't want to be using it for any more than a year, and maybe even shorter than that. And you need to monitor it very closely. And again, you consider other treatments if the disease relapses rapidly after stopping cyclosporin. And then there's acitretin, and again, this is a retinoid. Again, you can click on the link there if you want more information about it. But you really want to use incremental doses to minimize the mucocutaneous side effects, such as dry skin. They can often get thinning of the hair, so they can often get side effects as you increase the dose. But they do say that you want to achieve a target dose of 25 milligrams daily in adults if tolerated. They do say that you can consider dose escalation to 50 milligrams daily. I can't say I've ever gone up close to that high with acitretin. I don't think I've really seen it in the departments I've worked so far. But then you want to assess treatment response after about 4 months and consider stopping it if it's inadequate. And then other medications, which I'd hope to discuss a bit further in time, are apremilast and something called skilarence, which is a fumaric acid ester. So the interesting thing about apremilast is that they claim that it doesn't cause any immunosuppression, and they also claim that you don't need close blood monitoring. So it's quite useful. And where I've kind of seen it in practice is oftentimes if patients have lots of comorbidities and other medications might be contraindicated, and it can be considered there. But I think probably the efficacy maybe not quite as good as other systemic agents. Don't quote me on that, but it also is quite expensive. So it definitely has a role in places, but it's not used a huge amount in my experience. It can cause lots of GI side effects. And the other thing is that there were reports when it came out that sometimes the mood could be altered with it. So, again, a rare association, but you always have to inquire about any history of mood issues when starting someone on the apremilast. And the other thing is they also report that sometimes you can get a bit of weight loss in it, which patients are always pleased to hear when you say that to them. And then skilarence, again, it's a fumaric acid ester. Again, I haven't used it a huge amount in the services I've worked, but it can be quite useful. It again is often a dosing regimen that you increase your way up over time. And just the key kind of side effect to be aware about with these is that it can drop the lymphocyte count. And I've seen that before when I've used it. And then if the lymphocyte count drops below a certain level, you are then at increased risk of the JC virus, which can cause a progressive kind of multifocal encephalopathy. So that's kind of the thing you're looking out for with skilarence. So I'll now move on to the biologics. And again, the NICE and BAD have criteria for the use of biologics in psoriasis. So they suggest you should offer biologic therapy to people with psoriasis requiring systemic therapy if methotrexate and cyclosporine have failed, are not tolerated, or are contraindicated, and the psoriasis has a large impact on the physical, psychological, or social functioning of the patient. And this is represented by a DLQI greater than 10. And one or more of the following imply a PASI score of greater than equal to 10. Now, the BAD guidelines also include, but NICE does not, that another factor where you can use it if PASI is not greater than 10 is that if the disease is severe and localized sites that are associated with significant functional impairment and or high levels of distress. As mentioned before, this might be nail disease or high impact difficult to treat sites such as the face, scalp, palms, soles, flexures, and genitalia. Now, it does suggest you could consider a biologic earlier in the pathway in instances such as if the methotrexate has failed or the conventional systemics have failed or not tolerated or contraindicated. Sorry, I'll go back on that. So they do suggest that you could consider a biological earlier in the pathway. For instance, only if methotrexate has failed, is tolerated, or not contraindicated if the patient has active psoriatic arthritis. Because in patients with psoriatic arthritis, you want to get their disease under control right away from the joint point of view, as it can be non-reversible. So then for all the biologics, it's really important that you then review them at a specified time frame. Now, this depends on the type of biologic agent you use, but it often is about 12 or 16 weeks. And you then want to assess if it's effective. And being effective would be a 75% reduction in PASI score or a 50% reduction in PASI score and a 5-point reduction in DLQI. So the VAD has very good guidelines on the use of biologics in psoriasis, and it often gives updates as well. And I find particularly the supplementary material and from the guidelines has very good information about each individual biologic agent. And a lot of the information I have below is taken from that. So, it's actually done probably in better format, definitely in better format in the BAD guidelines. So I would refer you to that. And I think that link hopefully should be effective. And the supplementary material is often good at a decision age, which you can use yourself to have to think about it, or you can also use it to help discuss the patients and kind of the risks of the various biologics and the efficacies and the various contraindications, et cetera, et cetera. So the BAD has a checklist which suggests what you should do when you're commencing a patient on biologics. So you should do screening lab investigations, including FBC or an EST, ESR, hepatitis and HIV serology. And you should do VZV serology, so zoster virus serology, and unless they've got a very convincing history that they've had chickenpox in the past. And you should do ANA, double-stranded DNA. That's particularly relevant for the TNF alpha inhibitors, in which there is a risk of lupus activation with these medications. And you should also do fasting lipids and glucose. That's quite good in general for the workup of psoriasis patients, as they often have associated metabolic disease. And then you should do a quantiferin test and looking for TB or past TB, and a chest X-ray, also looking for any past evidence of TB and any of neoplasm. And then the other important things to do is that you should recommend a pre-treatment flu and pneumonia vaccine, and then I suppose COVID vaccines as well. And I'm not sure if that will change over time, but I suppose it's probably good practice to advise that. And then you should ensure that they have cancer screening that has been performed appropriate to the patient's age and gender. So just up here that they should get cervical screening every 3 years, from the ages 26 to 49, and 5 years from 50 to 64. And breast screening should be performed in women aged 50 to 70 for every 3 years. And then if they're over 70, they can get a self-referral. And those are the UK guidelines. Like I looked at them probably about a year ago. And then I think that, depending on the age, you might want them to get some colorectal screening as well. And I think it's QFIT is the test you do. So I'll now move on to the mechanism of action of biologics and talk a bit more about psoriasis pathogenesis here. So essentially different biologic agents exert their effects by targeting specific cytokines in the psoriasis pathway. So it's useful to have this basic knowledge of inflammatory pathways involved in psoriasis. So keratinocytes often can respond to various kind of triggers or traumas, and by releasing substances that can activate dendritic cells. A dendritic cell can then determine what happens to a naive T cell, and it can push it down a particular pathway. So for instance, oftentimes, in eczema, the Th2 cells are often activated, and they cause a pathway to be released, which causes release of IL-4 and IL-13. And these are the cytokines that are used in eczema. But in psoriasis, the Th1 cells and the Th17 cells are the main T cells involved. So I'll talk a bit now about the Th1 pathway. So in the Th1 pathway, IL-12 is released by the dendritic cell. This then activates Th1, and then Th1 makes interferon alpha and TNF alpha. TNF alpha is classically involved in anti-tumor activity, and interferon gamma is classically involved in fighting infections such as viruses. Now, the Th17 pathway, in this, the dendritic cell releases a range of cytokines, including IL-1A, TGF-beta, and interleukin-6. And these all turn a naive T cell into an inducible Th17 cell. And then the cytokine IL-23 turns this into a pathogenic Th17 cell. And this releases a whole range of cytokines, including IL-17, which is very important, IL-22, and again, TNF alpha. And basically, between these two pathways that I showed here, this cascade of cytokines can lead to, in various ways, to what we get with the plaque that we see in psoriasis. So different biologics then target different cytokines in these pathways. So anti-TNF alpha agents were kind of the original biologics, and adalimumab is the one we usually use. It's generally the first line biologic due to its cost effectiveness. But there is etanercept and infliximab, and there's something called certolizumab, which we'll go into more detail. That's the useful option if a woman is thinking of conceiving or is pregnant and needs a biologic. Then we have the IL-12/23 inhibitors. That's called ustekinumab. The trade name is Stelara. IL-17 alpha inhibitors, which include secukinumab and ixekizumab, and brodalumab, which is an inhibitor of the IL-17 receptor A receptor. And we have something called IL-17F inhibitors, which is bimekizumab, which is a newer one. And then we have IL-23 inhibitors. And these are called guselkumab, risankizumab, and tildrakizumab. I'll go into the mechanisms of these a bit later as I go into them. So when we're talking about the anti-TNF alpha agents, these are the original ones we used. Of course, they're used in other conditions such as inflammatory bowel disease and rheumatoid arthritis. But essentially, both the Th1 and Th17 pathways can lead to increased TNF alpha, as noted here. And the good thing about the anti-TNF alpha agents is that biosimilars exist for them all, except for certolizumab, so they tend to be quite cost effective. And they're usually given subcutaneously, apart from infliximab, which is given IV. The important thing to be aware about the anti-TNF alpha agents is that they are contraindicated in active TB, and they are also contraindicated if the patient has a history of multiple sclerosis or first-degree relative with multiple sclerosis. And the reason is for this is that there have been reports where MS has been caused by them. And then the other thing to be aware is that it can exacerbate advanced heart failure. So it is contraindicated in the New York Heart Association grade 3 to 4 heart failure, if you can remember what that is from your membership exams. So latent TB is a relative contraindication. So it has been used before in latent TB and it's absolutely necessary. But it really needs to be discussed with an ID specialist. And also there are other biologics that probably have less risk of TB reactivation. So they might be a consideration in those cases. So I'll talk a bit about for each biologic agent. As I said, I've taken a lot of this information from the supplementary material. I'm not going to go into all the detail about the various doses of them, but this can be used as a reference point if you want in the future. So adalimumab, oftentimes the loading dose is 40 milligrams. Then you get 80 milligrams loading dose. Then you get 40 milligrams at week 1, and then 40 milligrams every 2 weeks. And you assess response at 60 milligrams. An interesting thing about adalimumab and some of the other biologics is if you use it over a long period of time, patients can sometimes develop anti-drug antibodies to them. And about 6 to 50% of patients develop antibodies to adalimumab, and this often will affect the drug's performance. So you can consider methotrexate with adalimumab, and if they have no contraindications and no prior intolerance, and this can sometimes prevent anti-drug antibodies. And again, this is quite specialist, so you probably want a lot of experience in dealing with psoriasis before you start doing things like this. And it can be used in children and young people, so it has been licensed from the age of 4. And usually you assess response at about 16 weeks. And just again in the supplementary material, which I find is quite useful, so you could counsel a patient that if they're using adalimumab, rough proportion of people that are going to have a 90% improvement in their PASI score at 3 months is 40%, and the likelihood of them staying on it past 1 year is about 77 to 81%, and the proportion that stops due to unwanted effects is 2%. And so, as mentioned, the contraindications will be moderate to severe heart failure and MS and TB. and it is also a licensed treatment for psoriatic arthritis. So certolizumab is an interesting anti-TNF alpha agent, or interesting biologic in general. So it's got a unique molecular structure. So it has no Fc region portion of the antibody itself. And so because it does not have this, it actually is felt that there is minimal or no placental transfer of the certolizumab to the fetus. So it is often the first line biologic agent that should be used if there is intent for conception. And it's got a reduction dose of 400 milligrams at week 0 to 4, and then mention it's 200 milligrams every 2 weeks. And you can increase it to the 400 milligrams if there's an insufficient response. And so it's not licensed in children and young people, and you can counsel a patient that the PASI 90 at 3 to 4 months could be expected. It's a rough proportion, so you had 90% improved PASI score at 3 or 4 months is about 41 to 48%. And the proportion that stop due to unwanted side effects is 2%. And the proportion that get a serious infection in the first 3 to 4 months is less than 1%. And again, the conditions to be hesitant about are the same for adalimumab. And it is a licensed treatment for psoriatic arthritis. And then etanercept and infliximab. So I don't think they're really used as much nowadays for psoriasis, as there are multiple other options. And so I won't go into them in great detail. So the etanercept can be used in children from the age of 6. And you want to assess the response at about 12 weeks. And again, the proportion that get a PASI 90, so a improvement in psoriasis of 90% at 3-4 months is about 23%. So probably not as effective as the other ones. And then infliximab is one that is often used IV, and you tend to have a higher threshold to commence it as per NICE guidelines. So they say you should have a PASI greater than 20 or DXY greater than 18. And it's not licensed in children and young people. And the rough proportion that get an improvement in their psoriasis of 90% at 3 to 4 months is 53%. And I suppose one issue with this is it's IV, so it's obviously a lot more cumbersome for patients to get it, as they have to come into the day unit or somewhere in the hospital to get it done. But I do know it is often used. So if they've gone through all the various biologics and it's not working, and then oftentimes it might be used in those instances. So we'll now move on to anti-IL-12 and 23 agents. So there's only one really on the market for this, and that's called ustekinumab. So if you look at the pathway that I'd done before, so IL-12 is involved in the Th1 pathway, and IL-23 is involved in the Th17 pathway. So the reason why ustekinumab works is that IL-23 has a P40 subunit and IL-12 has a P40 subunit. So ustekinumab targets the P40 subunit. And so dosing for ustekinumab is weight-based often. So it's often 45 milligrams, and if they're less than 100 kilograms, and then 90 milligrams if they're greater than 100 kilograms. And you usually give it at week 0 at the start, and then at week 4. But then quite one of the useful things about this medication is then that it's every 12 weeks. So that's quite handy for the patients. And it can be given in children and young people from the age of 12, and that there's a dosing regime for the children. And they actually say here that the indication is to stop if there's a poor response at 28 weeks of treatment. I suppose because it's less frequent dosing, they kind of give a longer period. But they do say you should do an evaluation of response also at 16 weeks. And you can counsel patients that the rough proportion that will have 90% improvement in their PASI score 3 to 4 months will be about 46%. And again, they have a high likelihood of staying on this past 1 year at about 86 to 92%. And again, a similar amount stop due to unwanted side effects of about 1%. And what if you have psoriatic arthritis? So it's actually probably seen as one of the biologics that is not so good for psoriatic arthritis. So you don't really consider this if you tried a TNF alpha inhibitor previously. And now, bad beer, just to mention, is bad beer is a large registry, and it's a real life registry of psoriasis patients. So any patients that can be on multiple systemic agents, and now it differs which ones can be used anymore, but many systemic agents that patients with psoriasis have and could be registered with this bad beer registry. And it's very useful as it's patients that are actually on the biologic in the real world setting that will be followed up on this. And so it reflects real world practice. Trials often have patients that, don't have many comorbidities, maybe haven't been on very different treatments before. So they're kind of, optimal patients really for treatment of psoriasis. So bad beer reflects how it works in patients that might be on many medications, many comorbidities, et cetera. So it's quite useful. So the only reason that I mentioned it here is that in 2015, a study looking at bad beer data and showed that the largest proportion of patients remain on ustekinumab at 3 years, and were compared to adalimumab, etanercept, and infliximab. And there's the link for the study there. So now move on to the anti-IL-17 agents. And so the Th17 pathway is kind of been more and more recognized as a very important pathway in psoriasis. And if you look here, and as I showed before, that the pathogenic Th17 population produces a range of cytokines, including IL-17. And IL-17A is felt to be a key cytokine in this pathway. So secukinumab or Cosentyx was the first IL-17 a biologic, and it are monthly injections. So you start with an induction regime of 300 milligrams. So that's actually 2 injections at week 0, 1, 2, and 3, and then they go on to monthly injections. And it's unfortunate that the 300 milligrams dose does require 2 injections, but that's just how it is. Now, at time of writing, now this is about 2 years ago, it was not licensed in children. This may have changed, but the indication to stop would be if they have no response by up to 16 weeks. But if they have had a partial response, they may improve subsequently after this. So you might consider continuing it if they have had some response in 16 weeks. A nice timeline to evaluate response is 12 weeks. And the rough proportion of people that have a 90% improvement in the PASI score at 3 to 4 months is reported as 60%. And the proportion that stop due to unwanted side effects is about 2%. And just of note, the conditions to be hesitant about are slightly different compared to the anti-TNF alpha agents. So if a patient has inflammatory bowel disease, and there have been reports that the IL-17 agents can flare that up. I think there was actually initial hope that because IL-17 is involved in the pathway in inflammatory bowel disease, that maybe it would be quite useful for this. But unfortunately, that's actually, it can be, you might be hesitant about prescribing it in patients with inflammatory bowel disease. And the other thing is that the interleukin-17 cytokine is felt to be an important pathway in fighting off candidal infection. So if patients have bad candida or recurrent candida infection, you might want to consider that also. And it is a recommended treatment for psoriatic arthritis. So one of the studies for secukinumab was a CLEAR study, and at 52 weeks, secukinumab outperformed ustekinumab in multiple domains, including PASI 75, 90, and 100. And there's the link to the study there. So ixekizumab is another IL-17 agent. It's also called Taltz. And the induction regime is 160 milligrams at week 0, and then 80 milligrams at week 2, 4, 6, 8, 10, and 12. And then once you finish the induction regime, it's 80 milligrams every 4 weeks. So it's quite a complicated induction regime. It's not licensed in children and young people. And again, if an indication to stop is if they show no response at 16 to 20 weeks treatment. If they had an initial partial response, it may subsequently improve beyond 20 weeks. So, and you might want to stick with it for a while if there has been a bit of a response. And then you can say to the patient, a rough proportion that will have a PASI 90 at 3 to 4 months is 72%. And again, you have the same conditions to be hesitant about inflammatory bowel disease and recurrent candida. Again, it's a recommended treatment for psoriatic arthritis. So the IXORA S study again showed that at 52 weeks, ixekizumab outperformed ustekinumab in multiple domains, including PASI 75, PASI 90, and PASI 100. Another anti-17 agent is brodalumab. Again, the difference with this is that it actually affects the receptor, and the IL-17A receptor rather than the cytokine. And dosing is 210 milligrams subcut at week 0, 1, and 2, and then the same dose every 2 weeks. It's not licensed in children and young people. Again, you consider stopping if there's no response after 12 to 16 weeks of treatment. Some patients who showed an initial partial response may improve with continued treatment beyond 16 weeks. And the rough proportion that PASI 90 at 3 to 4 months is reported as 73%, and the proportion who gets serious infection in the first 3 months is less than 1%. It is not licensed for psoriatic arthritis. And then there is an Imagine 2 study, and this showed that at 122 weeks, so quite a long duration of assessment, that brodalumab outperformed ustekinumab in multiple domains, including PASI 75, 90, and 100 response. So from the studies, it appears that IL-17 in addition is possibly clinically superior to both ustekinumab and anti-TNF inhibition. In general, though, in practice, we are still encouraged to use adalimumab if there's no real contraindications due to cost effectiveness, and also just because it's been around for longer. So, there's probably still more robust data, although the data seems to be quite robust on the IL-17 agents at the moment. So as I mentioned, there are some in the considerations with IL-17 agents. So as I mentioned, IL-17 is important in gut inflammation, and 50% of patients with IBD in trials had worsening IBD. So if they develop lower GI symptoms on IL-17 inhibitors, you should screen for IBD with a fecal calprotectin and plus or minus gastroopinion, depending on the situation. They're also at increased risk of mucocutaneous candidiasis, and it was felt that it could be safe in latent TB. Therefore, you could potentially proceed with a positive quantiferin test, but again, you probably should be cautious if you're not too experienced with it, and speak to the ID team regarding whether they need latent TB treatment. And then there was a bit of a query with brodalumab specifically about whether this could have issues with depression. So some of the early reports or trials showed 2 patients who had suicide and 1 who developed severe depression. And when analysed, it was felt to possibly be circumstantial at the time, but it was felt that you should still exercise caution and screen for people with depression if considering this agent. And then with regards to psoriatic arthritis, as mentioned previously, it's ixekizumab and secukinumab that are licensed for use. So now we're moving on to the anti-IL-23 agents. And if we look at the pathway here, IL-23 is upstream and compared to IL-17, IL-22, and TNF-alpha in the pathway. And IL-23 controls the survival of the pathogenic Th17 cell population. So as mentioned before, ustekinumab, which we talked about before, targets P40, which targets IL-12 and IL-23. However, these agents I'm going to talk about just target the P19 subunit, and as a result, they only target IL-23. So guzokimab is dosed at 100 milligrams subcut at week 04, and then every 8 weeks. It is not licensed in children, and you consider stopping it if there's no response at 16 weeks. It is quite effective, and the rough proportion that get improvement in their PASI as 90% is 68% at 3 to 4 months. And the amount that stop due to unwanted effects is about 2%. It is not licensed for psoriatic arthritis. Risankizumab is another medication, anti-IL-23, and induction is 150 milligrams at week 04, and then every 12 weeks. It is not licensed in children, and again, you consider stopping it. No response at 16 weeks. It is very effective. The rough proportion that get a CASI 90 at 3 to 4 months is 74%, and the proportion that's not due to unwanted effects is 1%. Again, it is not licensed in psoriatic arthritis. And then tildracizumab or Ilumetri is used with an induction dose at 100 milligrams at week 0 and 4, and then every 12 weeks. If they're greater than 90 kilograms, you can increase the dose. And if they've got very high disease burden, you might increase the dose also. Again, it's not licensed in children. And you stop if there's no response at 28 weeks. And proportion that's not due to unwanted effects is 2%. And it is not licensed for psoriatic arthritis. So that is, I know, easy to get bogged down in all of them, but hopefully that's gone through them in relatively straightforward way. Now, there are various considerations that you might have when starting patients on biologics, and particularly you need to think about conception, pregnancy, and breastfeeding. So with regards to pregnancy, lots of women's psoriasis during pregnancy actually improves. And remission during pregnancy is associated with a HLA-CW6 genetic variation. And approximately 6% of these patients may go into remission. As I mentioned, that is the susceptibility and the locus that has the highest association with psoriasis. And so sometimes women may elect to even stop treatment once they conceive, but unfortunately, patients can also get a flare when they have psoriasis. It is rare, but it's not infrequent. And some registry-based studies have linked particularly severe psoriasis with adverse maternal and neonatal outcomes. So although there is some conflicting studies on the subject, and it's definitely something that needs to be considered, that, is it very important to get this severe psoriasis under control and for optimal pregnancy outcomes. So it is important to advise women of childbearing potential by contraception if they are taking biologics, and particularly if they are not planning to get pregnant. However, if in women who are planning conception or who are pregnant, you need to counsel them on the importance of controlling the severe or unstable psoriasis, as I mentioned. Now, there have been pregnancies that have been reported of women exposed to TNF antagonists at conception and during the pregnancy. And many of them have had successful outcomes with no increased note of stillbirths, congenital malformations, or preterm births or neonatal infection. However, it is felt that exposure to TNF antagonists at pregnancy